All right, now we're cooking.
All right, we're cooking with fire.
So you were just saying you're in Austin right now.
Yes, yeah, I'm in Austin, Texas. I'm from Chicago originally,
What'd
and
you do down there?
my wife and I were kind of from the suburbs of Chicago. Did all my training out there, dental school, oral surgery residency, and I actually worked out there for about a year and a half. When I finished residency, it was in 2020, just the height of the pandemic. It was kind of crazy at that time, and started. It was great actually, fee for service practice. It was a very talented surgeon I was working with at the up kind of the North Shore, really nice area, and kind of had the itch to build my own thing. And I think once you get that itch, it's hard not to scratch it. And we had some family in Texas, and really wanted to build the office in an area that had a little more kind of growth potential. Especially, I mean, it's a scratch start, so I was like, well, let's at least optimize it in a way where we can be close to family because we had our first kid at that time, and we can get away from the winters. I will say, I mean, I miss some elements of the city, restaurants, and just kind of the culture. But I mean, Austin's great. I'm like 30 minutes north of the city, and it's been a lot of fun. I've been out here for like 4 years now, actually.
Yeah. What? So 2020, 2021. I guess 2021. It was in the middle of or just after COVID got going.
Yeah. I finished in 2020 residency, like summer 2020. Moved out here, and it would have been like December or January 22. So yeah, just about like 3.5 years now. But no, it's good. It's good. I'm really enjoying it.
Nice, man. Congrats. And where'd you go to residency?
University of Illinois Chicago. Dr.
Nice.
Maloro and that group. Yeah. It's a great experience.
You did
Very
the
well rounded.
4-year track, right?
4-year track. Yep.
Nice.
And by the way, I think before we even jump in, congratulations, man. I mean, that's kind of well overdue. I think well deserved, huge accomplishment, and I don't think that should go unsaid. So just really, congrats, man.
So it's another step, another check on the list, and I mean now is when the real fun begins. That's what I believe.
Absolutely, no, that's a great attitude to maintain.
Because I mean, you went right into practice. You were still in Chicago. You said your wife is from Chicago.
Yeah. We started dating in dental school.
What does she do?
She's a general dentist, actually. So
Nice.
she when I was in residency, I mean, you know how it is, like the amount of hours you're working. So she just works like crazy at a nice practice in the burbs. And after we moved to Austin, she was pregnant with our second. So it can be kind of hard to get a nice position, when you're like 6 months pregnant. So had the baby. She was kind of working as an associate at a place that she enjoyed. It wasn't the same as Chicago. And as soon as I got my practice open, she's very like type A. She's an operator. She's very much organized. And I was like, I think you got more value for us at least getting us started. Helping run the office. And she loves it. And she's kind of been doing that. Fast forward now, we've got baby number 3. So right now, she's basically runs the office. It's set up so that I can kind of show up, do the surgeries, focus on quality patient care. And then, I'm very involved in some other things I'm passionate about. This is what the schedule has kind of unlocked, that ability to have your clinical practice and being able to practice the way you want while also pursuing your passions and other interests, like just like yourself, right? I mean, you have this platform, the mentorship that you provide, having that balance. It's not only giving back to the community because of all I'm sure hundreds, if not thousands of students you've helped, but it gives you balance, right? And I'm sure you can speak to this. It's a grind. I mean, you just got out of residency, man. So you're the face of it, but the balance of the schedule between 100% of your life doing oral surgery and running the business compared to, one or the other, meaning like doing some surgery but working on something else, or like running the practice and not doing surgery. So it's some folks can do it all the more reason, all the best to them. But if you want to pursue other passions as well, which is fine, all related to what you're working on, having a schedule that allows you to do that, for sure, it's a big hack for sure.
Tell me about your schedule then. I want to hear about this. What days you work in? You work weekends at all? What are your hours?
Yeah, when I first kind of came down here, it takes a long time to build a practice. Like it's, the whole interior build out. I mean, it's a lot of work, a lot of learnings along that route too. But what I was doing is I was working, I was doing a couple days a week at a full arch kind of corporate center type of place. And then I was working as part-time. I met some great docs here in Austin who were I was fortunate enough they let me work with them, on a part-time basis. So I was doing 4.5 days a week, while I'd say like a half day a week. for like, contractor meetings and design meetings, like you need a little bit of time, because most of the people you work with, they don't really operate at nights and weekends. If it's like a contractor, a designer, the plumber, all this kind of stuff, you can't like hop on a Zoom with them at 8 o'clock. So
Right.
you got to have some of that time. So I did that for a while, and the number, I ended up doing a little more time with the full arch place, and I almost treated it like a full arch fellowship in a way, where I was just kind of getting a bunch of arches done. I'm really passionate about full arch implants and remote anchorage, zygomatics, pterygoids, transnasals, that's like a whole kind of subspecialty almost, if you will. Fast forward about like maybe like a year and a half, 2 years, we opened the practice, and I started just 1 day a week. And then I kind of bumped up to 2 days, 3 days. Now I'm at 3.5 days a week, and I kind of, like backed off from the other places. And right now, to me, that's perfect. It's 3.5 days a week. I've got a full day plus a half day to work on other stuff. And of course, it doesn't really include nights and weekends, but that's at least for like the patient care. I think that's a sweet spot. But yeah, let me know what you think, man. I mean, you're about to start soon, right? Your new setup.
Yeah, I'm starting soon. So this is the Full Arch Pro. Is this
Yeah.
the whole thing? This is the
Yeah.
component, because I want to get into those side projects you're talking about.
For sure.
I can't agree more with that balance. You need to find your hobbies, whether it's dieting and cooking, or exercise, or playing an instrument, or starting other side projects, businesses, art, painting, whatever it may be. You get to, but this, I love this. This looks great. I love
man.
the logo. I love the logo. Just
Oh yeah, thanks, man.
Yeah, man.
Yeah, that kind of came out of.
But yeah,
I'll kind of give you the backstory, which was so the office I joined here. If you're familiar with Dr. Dan Holtzclaw, he's actually a periodontist, but he kind of wrote the main textbook, at least probably the most well known one, on pterygoid implants. And he's been doing them for just super long time. And he had a practice out here just north of Austin, and it got really busy. It was kind of a full arch practice. He got super busy. He ran a really great shop. And if you heard of Dr. Juan Gonzalez, he's a oral maxillofacial surgeon. He started working with Dan over there. And the story goes that Juan taught Dan how to do zygos, and Dan taught Juan how to do pterygoids. And just to give you a timeline, this is a long time ago. We're talking like 10 years ago. So at that time, you can imagine, nobody had the ability to do both pterygoids and zygos like in one place. And they kind of became this center where, I mean, people were like flying across the U.S. These really, atrophic maxilla cases, really tough ones, revisions, all sorts of stuff. That kind of became this practice's reputation. And around the time where we were looking to move to Austin, there was an opportunity for me to go meet Dr. Holtzclaw, and I went and met him. And in residency, I had published a paper on zygomatic implants and kind of approaching them from more of a prosthetic perspective, like restoratively driven. That's what it's called, the restoratively driven zygomatic implant routine with Dr. Maloro. And I think that kind of piqued Dan's interest. So he's like, hey, let's bring this guy. So I kind of became the third guy, and it was just an amazing experience. I was able to kind of work with Dr. Gonzalez, Dr. Holtzclaw. I really kind of learned about their way of thinking. The Dan came up with this protocol. He published on it, which is basically like full arch, so all on four, but with pterygoids in the back. And this concept of eliminating the cantilever, he started to notice, he's like, I was only doing these in the beginning as a salvage. So like when the cantilever would break and there's a lot of bone loss on those tilted implants, there'd be some kind of revision, and he would put a pterygoid back there, and then it would kind of save the case. And what he started doing, he's like, what, like, why don't we start putting him in from the beginning? Because that way they don't even get that load of the cantilever. And he published on this concept that he calls the PFAST, or the FAST if the P is silent, the pterygoid fixated arch stabilizing technique. It's basically all on four plus pterygoids. And you got this beautiful, nice arch length, 0 cantilever, 6 implants. And then for some of the more atrophic cases, so some of the cases where the sinuses are super like pneumatized, not only like inferiorly, but even anteriorly. So if you were to do like a regular all on four, your AP spread would be like canine to canine, or like first premolar to first premolar. And the patients are like, can I get more teeth here? Like, so now it's either you're bone grafting or you're doing, sinus lifts and waiting, delayed load, all that. or you put a zygo, right? And that kind of
Yeah.
became the go-to. So basically, this whole concept turned into what's called the PATSI protocol, PATZI, which
Mhm.
stands for posterior anterior tilted zygomatic implant, where you can do the same kind of thing, like 6 implants, full arch length, no cantilever, no graft, and essentially you can approach any arch in this way. And I was like, guys, like there is something here. Like you understand, like we can really build on this. And I myself and the guys, we put out this paper, the Patsy Protocol paper, which essentially builds out like a master equation or algorithm, so to speak, of posterior, anterior, tilted. And if you can't get one of them for some reason, there's like a fallback and like a zygomatic implant placed in a different angulation. I don't want to get, maybe we're getting a little too technical. I know the audience. Basically, that's why I started Full Arch Pro, because I was like,
Yeah.
there's a whole community of folks who want to learn this stuff, who want to kind of get either getting into Full Arch for the first time,
Hmm.
or maybe they're like they've been doing it and they're like, well, I'd like to be able to have it in my armamentarium to do a pterygoid implant, or a
Right.
zygomatic implant. So I started Full Arch Pro, and basically we kind of did some lectures and we did some courses where I used that as a platform to basically bootstrap the very early uh, minimum viable product of Toothsome, and we can come back to that later.
Mm.
But that's kind of how I approached it. But the balance that you talked about, like having a way to be able to explore your curiosities, to be able to kind of express your interests outside of the operating room.
Yeah.
I love what you said there, because to me that's really important for your longevity. There's all this speak about like burnout and everything with residency and
Right.
just healthcare, and having something where if it's something you enjoy and it's something that genuinely helps people, I mean, why not? Why not pursue that?
Yeah, and it's escapism. It allows you to explore other areas. It's a relief from one side of your brain, working on the other side, perhaps. I totally agree. Yeah, yeah, man, dude. This is so you're really getting into and you're fresh out of residency, just a couple years. You really maybe four or
Yeah, I
5 years
mean,
out. You
yeah,
really
about 4 or 5 years. Yeah.
not fresh. I mean, I'm literally I'm a couple days out. I didn't mean like that. I
Congrats,
mean
baby.
like you have your whole career ahead and you're hitting the ground running. Is that implant center you were talking about? It's those two guys.
Yeah, it's kind of dissolved a little bit since then. There is some corporate ownership and things. It isn't the same as it used to be. They're no longer there. I kind of stuck around as long as I could to try to help out, but recently now it's shutting down, and you know how things go with the when private equity gets involved, and there's a lot of transitions that need to be handled.
Shutting down? Yeah, I understand that, but shutting down is a complete 180. Wait, so wait, I just want to go through this because you said you were is that the place you're working at 4 days a week?
Yeah, I put in 3, and then I kind of cut back to 2, and then to 1, and then I was kind of just going every so often.
At what
So
point were
recently,
they leaving or left? Did one leave before the other? Why did they leave? Were they partners or were they a part of a different organization?
yeah. So basically, they were pseudo partners. I don't know the details exactly with like the way the equity was structured, but Dan basically was in talks with getting absorbed by a corporate entity, essentially. So what happened is when that transition happened, they brought me in because they had Dan step up as like a chief clinical officer, which
Of course,
means
there's
like
always the chief
recruiting.
clinical officer. Oh yeah,
Yeah.
we're gonna give you this big title. You sell out, we give you all this equity. You can't take it out of the system though. You gotta hold on to it. You gotta invest in it. Yeah,
Yep, on
yeah.
contract, and,
Uh,
and they had him do a lot of teaching and a lot of recruiting. So he was away from the office quite a lot actually in the beginning. It was honestly mostly me and Juan doing a lot of the
mm,
surgeries. So he was kind of already, and they bring him in for like certain special patients that really wanted to see him and stuff like that. And then after like I want to say like a year and a half, 2 years, Juan kind of moved on because things change a lot, right? Like the culture, like a lot of things change. And then for a while, it was honestly like I was the only oral surgeon there, a really talented restorative doc there who did some surgeries, and I kind of just stayed on just out of respect for these two docs that built it. But
yeah.
my office got busier, and I did what I could, and then I just heard recently they're actually shutting it down. So it's unfortunate, but we were able to we changed a lot of lives over there for sure.
No, that's what organization? Can I know what organization was
Yeah,
it?
it was the parent. So the parent organization was Affordable Dentures and Implants. They're like a DSO for like mainly like for just dentures and overdentures,
Yeah,
traditional dentures. When
good
they
career
when they
choice.
bought Dan's, yeah, yeah. Well, when they bought Dan's practice, because it was a full arch, like fixed only, they were like, well, we'll use this practice to launch our new like full arch sub brand kind of a thing. So they actually opened up multiple of them. Like there were some like in California and in Arizona, and the Austin one was kind of like the hub. People would be other affordable offices across the U.S. would send their like really tough cases to us, and they'd like fly them out, and it was like the whole thing. So it was it was an impressive operation for some time, but I can't speak to like the business operations and that kind of thing, but we did great work. I mean, it was like super high quality, full arch, zero cantilever, no grafts, just really good quality.
Yeah. Yeah. What were they giving you a fee per day, a salary, a percentage?
Yeah, it was like a fixed fee, like per kind of per arch, and it depended because some of the arches are more complicated. Like if it was like a zygo or quad zygo, there's more compensation for that. That's how a lot of these are structured. Like your Clear Choices of the world, Nuvia is like blowing up as far as like
Mm-hmm.
how many of those offices I see them all the time.
Yes, it is.
Um, and it's a little bit different because in private practice, I do arches now in my practice where I work with like a restoring doctor of my choice, or they'll refer it to me. So I've kind of seen both sides. I've seen like the implant center model, which is kind of everything under one roof. And if they hopefully they have like surgeons like periodontists, oral surgeons there, because not all of them do, by the way. Some of them it's just like the general dentist does everything, including the surgery. And then in my model, we're very much like traditional. They usually see us first, just for a general consult. We'll do the workup, and then I have a prosthodontist here that I really like, and I'm kind of more picky with like, who we do the case with. I mean, at ADIC at Advanced Dental Implant Center, I was spoiled. I had like amazing docs
Mm-hmm.
for restorative support. When you come out in the community, and I've got like tons of referrals for like wisdom teeth. I mean, those docs don't necessarily feel comfortable doing full arch restorations. So if you're like, sure, I'll walk you through it. I'll do this because this is a strategy a lot of oral surgeons do.
Mm-hmm.
Is they'll say, hey, listen, like I'm talking to you as a surgeon. You do the case and kind of show them how to do it. But the problem is with that model, the volume can be pretty low. So they're not really kind of comfortable like taking on and off the teeth. They're dealing with complications, prosthetic complications, screw loosening. But what happens is the surgeon ends up dealing with a lot of these like restorative complications. So it's just not really my style. So we kind of have it like old school where I got a prosthodontist who restores it. I'll do the surgery. Even do the getting them into temps and everything because I got a lot of that training over there with photogrammetry and the whole
That's
digitally
huge.
printing the temporary teeth now, which is
Yeah, your
it's
digital
just so nice.
attempts. Nice, nice.
Yeah.
That's a big help for the patients when they can get all that done in a day. Go there, but then you're still involving the dentist that's going to restore. That's a prosthodontist. They're gonna. Do they do other work on? Do they also do general dentistry work or just
Mm-hmm.
restorative stuff? Okay, okay. So are some of those people that are referred to you that need that surgery, and you end up working with the prosthodontist? Do they kind of get absorbed into this new kind of partnership between you and the pros, or are they still seeing their general dentist that they got referred by? You know what I mean? This is
I got you. Yeah, usually they become the pros patient completely. That's kind of yeah. I mean, I don't think he really sends them. I mean, usually it's kind of like, hey, they kind of took over ownership. I mean, sometimes we'll get patients that come to see us that have a general dentist, and I'll even call them. I'm like, hey, man, like I think this is a full arch case. Do you restore these, or kind of like what's kind of your comfort level? And a lot of times they're like like sometimes they'll be like, hey, like I want to get into it. What's your process? And we'll kind of see if it's a potential fit. But I'm probably not the best example because I'm really picky about it. Like I want to have control over it. I want it to be predictable. I want to know that once we do the surgery, all the restoration, everything that's going to done afterwards is going to be just like tip top. Which honestly, so much of that happens from the very beginning.
yeah. Oh
Like
yeah,
the
yeah.
planning, it's all about the planning, from the beginning.
But I mean, I've done 21 or 22 full arches all in X's, but
Dude, that's really good, man.
much more to learn.
That's really strong
I was
for
very happy to
residency.
get that for residency, but there's so much to learn. But I'm just agreeing with you because in my limited experience in this time, it all starts with the restorative driven plan, right? It all starts with the vertical dimension of occlusion. It starts with what kind of AP spread are we looking at here? Do they
Yep.
have enough bone in this area? How much reduction do we need? Yeah. Do you plan it on a system or using Blue Sky, using DTX?
Yeah, so usually what we do is the prosthodontist, like they'll kind of do their initial workup with like he uses like traditional photos, and then he'll do some communication with the lab. Then usually he'll tell me and kind of say, hey man, like if it's like a super high smile line case or something, like we gotta take a little extra. But if it's like a low smile line case, we'll typically shoot for like 16 millimeters just for a little bit of buffer there. And
Yeah.
we kind of know each other. That's kind of the nice thing. That's why I like a small circle when it comes to who you work with for full arch, because we know each other so well that you know, he kind of knows the way I do the surgery and that it's always going to have enough, reduction. I know for him, like if there's anything weird, he's gonna be like, hey, make sure you check this out or check this out. So there's a lot of synergy there.
Right.
So the workup, mainly, I mean, from my perspective, a lot of it's going to be on smile line. Because if they don't have a smile line, or a high smile line, we're going to go with as little alveo as we can. That's restoratively appropriate. So typically your 15 millimeters is minimum for acrylic with a bar. 99% of the time we're doing zirconia, and you can actually get away with a little bit less. They say you
Right.
can do like 12 millimeters. I still kind of prefer a little bit long, like more like 14, 15 millimeters.
Yeah. Okay. Okay.
Um, yeah, but that's kind of our process. And it's interesting because that subset of patients, full arch patients, these patients are the ones with terminal dentition, right? I mean, like they need all their teeth out, chronic perio, severe caries. Maybe they've had a bunch of treatment over time and they've tried to have a lot of stuff restored, but now it's like a roller coaster. It's a unique patient population because they are the ones that have the most need from a dental perspective. They typically got there for a reason because they don't like the dentist, or maybe there was some neglect at some point in their life. And they're somehow expected to get the most expensive, most involved treatment that exists in dentistry, in my opinion, is full arch implants, like without getting into like really specialized stuff. And it's like, well, how do you connect the two? You got this on one hand, someone who doesn't ever want to go to the dentist, and then you've got like super specialized procedure. How do we match the two? And that concept, from if you put on your like economics hat, that concept is called information asymmetry, right? Where you've got two parties of these specialized doctors on one end, and then you've got these highly in need patients who don't even go to the regular dentist, let alone like a specialized dentist. So how do we connect those parties? And that's actually what kind of led me to some stuff I do on the side, which was just kind of being a patient advocate, or kind of help do some care coordination. Like in my spare time, I would go in these Facebook groups and I would see patients just like really upset, saying that they went to 4 or 5 dentists. They said they could never get implants. Like one of them said I could fly to Florida and try some bone grafting, and I'm like, just send me your X-ray. Listen, like I'm an oral surgeon. Like how bad could it be? Like send me your X-ray. And I look at it and it's like super atrophic, and that's probably why everybody was saying no to her, because it was a very complex case. It's a zygomatic implant case. And I said, listen, like yes, you can get implants. Like where do you live? Like where are you? And they were in this is the first patient we were able to help. She was in New York. Brendan, do you know David Zelig?
That sounds really familiar.
He's an oral surgeon up there. He's like one of the gods in full arch, like zygos, pterygoids.
I was gonna
Yeah,
say it sounds very familiar. Yeah. Yeah. Yeah.
transnasals. An excellent surgeon, really good guy. But I was like, listen, go see David Zelig. He will get you. He'll take care of you. And I called him and we kind of arranged this referral. And she saw him. She got the surgery. And the messages she sent me, I mean, she was sending me pictures of her going to karaoke. I mean, just totally changed her life. And she's like, without, I mean, it took me like 10 minutes, I mean, without someone just taking that extra step to say, listen, this is really complicated. Let me just hold your hand through this and get you to where you need to be. This concept of like care coordination, I actually felt, which is interesting, I actually felt the same fulfillment and like reward that I do when I do the surgery and like we see the whole transformation. I had that same feeling, and I've never even met this patient. I
Yeah.
did this like virtually, and that was the inspiration behind what Toothsome is essentially. And we can kind of get into it. There's several, I think I sent you, there's like several concepts there, but connecting those two disparate parties together
Mm.
is an immense project, because hundreds of patients every year, they give up. They're like, we're never, it's too
Right.
expensive, can't do it. They told me I'm not a candidate, move on with my life. And we know that there's a profound impact on one's oral health and their mental health. This is something that I was talking to Dr. Auerbach about. We all know about the oral systemic connection, right? It's no longer a debate. I mean, I think in the 80s it was like, no, we have data for that, hard data. Chronic health conditions, even the medical spend on those chronic conditions go down when they get appropriate dental care. But what we don't talk about is the mouth-mind connection. This is something that I like to advocate for, where we have data showing that with poor oral health and missing teeth, people can't even get interviews for jobs. It affects their self-confidence. It affects the way that they show up to work every day. It affects their self-esteem, their mental health. So by being able to facilitate those patients to transform their smiles, it not only makes them healthy, like the textbook, like we're taught these things in school, like it's all about oral health, but look at the impact that it has on their social lives, their personal mental health journey, their
Careers, yeah.
emotional lives, their careers, professional life even, So to me, that's extremely rewarding where if we can do this at scale where hundreds of thousands of patients are not getting treatment because they just don't have the information or they don't have the finances, how can we at least minimize information asymmetry and connect those two parties?
That's a really great concept. And so you really get into that's what Toothsome is.
That's kind of was the original inspiration for Toothsome.
Tell me, I want to know more about Toothsome because I also have a project that I'm working on with my buddy Sean from dental school. And it starts with what we have right now, the pre-dent mentor map, which is growing. But that's also, in a sense, we have a whole roadmap planned out. That's also, in a sense, just a prototype for a much larger thing that I want to hear more about you because it sounds like what you're doing now, which is in a way kind of like a back end service. Our thing is more like it'll provide a back end service that would, it sounds like very similar, but it's more of a front end visual model of a map. Tell me more about Toothsome before I go into that too far.
Yeah, for sure, for sure. Yeah, it started out as kind of this like matchmaking kind of a service where we would take patients who they would kind of just tell us what they needed. I mean, some patients would be like, "I need implants," but it was really like veneers or something. So
And who's
it
tell
just
me
goes to show you.
who's we? Is it you and your wife? Is it other people? Is it receptionist? Like
It's myself, and we have a really small, scrappy team. Like it doesn't get any scrappier than our team. And it started out with just trying to match a patient with whatever their needs are with the appropriate provider. So, like for example, like if someone needed full arch, they've already been seen by a handful of consults, and then I look at the X-ray and I find out, well, this is why they're saying no because you've got no bone. Like you need like zygos or something a little difficult, I think, to find out there. It's not every day that someone like knows what zygomatic implants are, let alone who does them. So that's where we would step in and just kind of help match them with an appropriate provider. Or sometimes it was price.
just
Sometimes it's finances. Oh, go
yeah,
ahead.
just one quick step back. It's only Facebook group. Like, where are you finding these people that need the match? Right? Is it Facebook group? Where else might it be? How do you get in touch with these
Yep.
patients?
Yeah, so in the beginning it was kind of just Facebook groups. Then we started having some like inbound interest. So for example, like that first patient, she like went on the Facebook group. She's like, guys, like, check this out. They'll help you. And we kind of got a lot of inbound interest because one of the nature of dentistry, unfortunately, is that there's very little trust left, in my opinion, when it comes between patient and
We're at an
providers.
all-time low. All-time
Yeah,
low.
I agree. Right. We are at an all time low. That's well said. And that's a complicated topic. We can kind of get into that. But the fact that like every implant advertisement you see, or not even implants, like veneers or whatever it is, dentistry, the person viewing that advertisement, they're viewing it and they're like, okay, it says, go see Dr. Gallagher for your implants. And there's an inherent bias there saying like Dr. Gallagher's the best, he's going to do your implants at this price. Inherently, I mean, the person writing the advertisement obviously wants you to see them, right? So there's an inherent bias. Whereas when you have a third party involved, some type of like care navigator or care coordinator, our value proposition is we say, hey, we don't really care who you see. We just want to make sure that you see somebody, and let us help you kind of on that way. So that element of mistrust, we were able to eliminate that because we're like, well, if you see Dr. Zelig, great. If you see Dr. Gallagher, great. Like, we're happy either way. We just want you to get there. And so we started getting a lot of kind of inbound interest and then started doing this matching. And then what was really interesting is we started to notice that the biggest feedback that we got from these patients were that they were all employed, they all had insurance through their employer. And they're like, why can't we use our insurance? How come we have to pay cash? They have to finance it. There's high interest rates. Like, it's very expensive, as you know. And they're like, listen, I've been paying into the system for like 10 years. Like, how come like none of this is covered? You're telling me like, listen, this is a complicated thing. And we kept explaining this over and over again. That, implant coverage is very little, if not at all, like zero sometimes. So then I started doing some digging and I was like, you know what? Like, why can't they just use their benefits? They've been paying into it. Like, why are we even paying, $1,500 or whatever it is if they can't even use it? And why not just put $1,500 into a bank account every year and then at least use it like cash? That was kind of the concept. So we started pivoting away from being more of like a direct to consumer company, like an implant matchmaker, where we basically kind of broadened the service offerings to a little bit more of like kind of the sexy stuff. Like, full arch, of course, is kind of the number one, but just regular dental implants, implant dentures, cosmetic dentistry, like veneers and Invisalign and stuff like that. Whitening even. But that's kind of like the sexy stuff. That's what people like want to go to the dentist for. You know what I mean?
Right. Yeah.
So we kind of expanded there, and then we said, hey, how about we do this? Why don't we start building a transparent benefits platform for employers? And I did some digging, and I found out that these employers, they're spending a lot of money on dental insurance, like premiums, like they pay every month, and they're paying for a fixed dollar amount. It's not a true insurance product like, medical insurance. Like if you pay your premiums, but if you break your leg and it's like $30,000 for the orthopod to fix it, that's catastrophic coverage. So anything above, it's covered. It doesn't matter how expensive it is. And it's more nuanced than that, but that's basically what real insurance is.
Yeah.
Dental insurance, you pay the premium every month, and you got, let's just say you need like 6 implants. They're only going to pay maximum $1,500. That's it. Even if your bill is like 20 grand. That basically means that whenever you show up and you do need extensive work, I'm not talking about your cleanings or your fillings. I mean, like, you need like a lot of dentistry done, what I call interventional dentistry, like active interventions. Because the coverage is so poor, the out-of-pocket bill is very, very high. And the higher the out-of-pocket is, the more likely patients are to defer the care and to not get it done. And they let it get, worse and worse and worse, and they end up in the hospital, right? Or they just need more and more done. The utilization of the dental benefit is suppressed artificially, in my opinion. And because of that, basically only 5% of employees ever reach the max, ever use the max. So can you imagine 5% of the employees in the US actually ever use the full maximum benefit?
Yeah,
and it's not because they don't want to, it's because the out-of-pocket bills are so high. So from an employer perspective, if only 5% of your people are actually fully utilizing it, can you imagine how much money they're wasting, right? So I did the research. In the US, it's about $50 billion of dollars that go towards premiums, a year, that go towards premiums for benefits that are not used. So what we're saying is just like, hey, Mr. Employer, I'm in Austin. So like Tesla, let's say, for example, hey, Tesla, instead of paying this fixed amount that you pay for premiums every year, so much of it gets wasted. Why not take the same cash that you already allocate for your employees, just put it into an account, like an escrow account, just put it in there. And whenever the patient wants to, let it accumulate, let it roll over, so it doesn't disappear every year. And whenever they do show up and they need like, several $1,000s worth of care, let them apply that cash like a gift card, like a stipend. Let them use it like cash. No middleman, no claims, no denials, no, yes, you can do this if it's the same day, none of that. Just use it like cash. And this concept is called direct contracting, and it's kind of blowing up on the medical side, but that's actually what we're moving towards from the dentistry side. Is number one, how to get more people to go to the dentist is by focusing on the sexy stuff like the implants, the veneers, the whitening. And then how do we get patients to get more dentistry? Let them use their benefits. Let them actually use them. Don't put up all these rules and middlemen that, make it difficult for dentists to get paid and make dentists take extreme discounts. Let's create a system where we can remove the middleman, work directly with employers. They want to save money, and then allow the patients to use it like cash. So it's transparent, it's easy, it's an ecosystem I think that's 50 years overdue, but we have technology now, right? It's 2025.
That's right.
We have the platform, right? I think specifically actually as an oral surgeon, I think you uniquely have a perspective about how dentistry, in my opinion, is a form of preventative medicine. It doesn't matter what it is. It keeps you out of the hospital. So why isn't that covered like a colonoscopy, or a mammogram?
Exactly. There's no preventative care really covered. Okay, sorry, I don't mean to cut you off. Keep going.
Yeah,
I was
gonna say I'll stop. I'm curious what you think, just kind of your thoughts as far as like what you've experienced. I know you've been in residency, but did they have you guys doing like peer to peers and stuff for some of the orthodontics, like on the insurance side, or like how much of the insurance stuff?
I don't want to do any of it anymore. I'm not going to. I can't stand that. It's so disrespectful to providers for these insurance companies to do this. They give you a nursing assistant on the phone, and it's nothing to the nursing assistant, but they don't even know anything about dentistry, let alone.
So you had a nursing assistant do a peer to peer?
I've had nursing. Hey, we're trying to hook you up with the right doctor and stuff. So then you finally you go to the nursing assistant, to the nurse practitioner, who they're calling the doctor. And when am I going to speak with a dentist, let alone a doc? Anyway, they don't understand the language. They don't understand what's going on. I'm seeing my co-resident. I'm not trying to throw this under the bus or anything, but they're submitting these medical necessities now to get implants and big orthodontic coverage over there using ChatGPT to get the right lingo in there that checks off all the boxes of these insurance
Interesting.
companies to get them approved.
Wow.
That's fraud. I would not. I couldn't do any of that. I couldn't sign that paper for that. I would not do that. But that's how a lot of these things are getting approved these days because they use you plugged into ChatGPT, you get the lingo that the insurance company is looking for. Like ostracizing. The teeth, the phonation is incorrect. They can't chew.
Oh, I
And
see.
the
Okay.
ostracizing, and then bang, bang, approval, and it's like, why do we have to play this stupid game? Anyway,
Games. Agreed.
let's get to the next thing. I want to hear more about Toothsome. Here's my thoughts.
Yeah.
Other big questions. One thing is there's so many denials, and dentistry is so expensive. But dentistry is going to be expensive. Historically, it was expensive. We created insurance companies 50 to 70 years ago to minimize the cost and allow the average patient to get care again. Right? Everyone puts all their money in a pool, and then it gets deciphered and goes out to these people providing the care, right? Well, now they're keeping a bulk percentage of that. More than 55% of insurance costs, quote unquote, goes to their administration. Who's in this administration? We have AI now. We don't need 90% of them, okay? But we can't get, anyway. The next step, I think, is it's way past the point of auditing insurance companies. You're saying direct consumer,
Direct contracting. That's
direct
the concept.
contracting. That sounds like an excellent idea. The other thing, though, is that's not going to provide care to these underrepresented communities. So that's an excellent way to do it. But I still do think this is where I want to get into. I've had this insurance idea for a year or more now. I actually created the algorithm on ChatGPT. That's why I want to talk to you about Toothsome. I do think, and it's a work in progress, but if we could create a new insurance company, in addition to creating a direct-to-consumer with these companies, because that'll benefit them, but we still have to benefit these patients that maybe they don't work for Tesla in Austin, right?
Right.
Maybe
Right.
they work at a restaurant. They need options for insurance.
Yep.
I think we need to get to an insurance company that uses AI to adequately reimburse treatment for providers. So now we could feed the providers what they need to keep their lights on, right? In preventative care, it's exactly what you just said. Not just maybe not even implants, because technically that's not a necessity of care in dentistry. Maybe they just need a Maryland bridge, a crown, a denture. That's what this insurance is going to cover. And then we can talk about the other things, but we need to get the preventative care and baseline care so that people can get it. And now the way this gets really good is it traces inflation. We use an algorithm, traces inflation. It traces the average mean income of certain, you got to break it down to location. It's got to be based off of, it can't even be towns or city. It needs to be like zip codes, maybe a little bit larger, maybe a little bit smaller. Maybe we couple zip codes, but this is how we get care in these underserved communities. I'm going to go on a couple little tangents here, but we're going to get back to the point. Dental therapists, they're trying to give them licenses to do like fillings and stuff. This way, in the middle of Squirrel's Crotch, Idaho, we could get these people with like losing their teeth, cleanings. That's not going to be the answer. How do we know this for certain? What happened when they created CRNA? CRNA, the Certified Registered Nurse Anesthesiologist. That way we could get them out into the middle of West Virginia to get anesthesia to these Where are the CRNAs going once they get that through? They're coming to Manhattan. They're going to LA. They're going to Miami. And now these hospitals get people that can do the anesthesia. They pay them less than an anesthesiologist. And now the anesthesiologist has to monitor 7 different rooms at once of CRNAs after 3 p.m. in the afternoon. So it didn't work, right? Are these CRNAs going to the underserved? No, they're going to Manhattan because they want to live in the city. They want to be in their own family towns. How do we get this to happen? So my theory is that we got to build this until it actually works. We need to use AI, the algorithm based on zip codes. The mean income puts a certain amount of money in the whole insurance company into that pot for that zip code. Okay. Certain, like, let's call just like Beverly Hills. Say they have a lot of money. There's going to be more dentists that want to work there. That's fine. And they're going to get reimbursed higher than a couple zip codes over where the mean income's less, right? But the algorithm does this, once you hit a certain cap in that community, then the reimbursement for filling starts to go down because say we could only cap at 100 dentists in Beverly Hills. We're at 115 now. We're at 120. The reimbursement per filling goes down. But in the couple zip codes over, in that underserved community, there's only 20 dentists there. It's never going to go down because there's so much money in that pot for that area. You could add another 30 dentists, or quote unquote, right? But this is the idea. It's got to be a pot per zip code that traces inflation, the mean income. Mean income goes down, well then maybe the reimbursement stays fixed. Inflation goes up, then maybe the reimbursement goes up. You get it, right? And now in the lesser served community, there's only 20 dentists. We could get up to 50 dentists maybe in this area, and they're still going to make the same per filling. But since it's only 20 dentists, They might be this is the point. They might be making more than the
Uh-huh.
Beverly Hills dentist
So it's
because
kind of
they're in
like
this underserved.
it's kind of
That's
like
it.
surge pricing, like for Uber.
It's
Like
financial
it's
incentive.
dynamic.
Yes, it has to be dynamic. You cannot have all these insurance companies and like Clear Choice where they want to pay you a fixed sum per day. That makes static and it makes it very simple to budget and to estimate the overhead. And that's how you really maximize a business because you could give sound numbers. But the only way you could give sound numbers in an actual area like healthcare is by using AI and it's actually dynamic. So anyway, you
For
get it.
sure.
This is how we get people in underserved communities. You need to incentivize it. You need like benefits, tax benefits, healthcare benefits, but most importantly, money. If you're going to tell people they're going to make more money in this area than in Beverly Hills, that's how they're going to go there. If it's just like 5 zip codes away, they could live in Beverly Hills and travel all the way out there. You get it. That's
Yeah,
an insurance company
absolutely.
that needs to be created now. You could eliminate 90% of the administration of the United Healthcare, whatever company.
Hmm.
You need to create this now. It'll feed the providers. It'll give patients more benefits. You'll call up the insurance company and it'll actually be a dentist just saying, hey, how can we help you? If you give us enough reason why this treatment needs to be covered or we need to increase our reimbursement in this area, we need to do it because we're your insurance company,
Hmm.
not the administration's, right? So anyway, that's my little
Yeah.
rant. And
Yeah.
I feel like that's really going to resonate with you.
Oh, for sure. I mean, so there's a couple things you said there I want to touch on. Number one is, well, first of all, I think it's an awesome idea. You should check out Garner Health, Garner, Garner Health, and Transcarent. These are on the medical side, but
Yeah.
they're basically like they're like insurance companies for the modern for the modern day. So the administrative bloat, all that stuff you're talking about. I agree 100%. I mean, so United Healthcare, like I'm just going to use them as an example. They have call centers with thousand, like I forget exactly. Don't quote me on this. I think it was like 100,000 employees that they employ specifically just for the call centers.
Yeah.
So it's 2025, right? So when we built these insurance companies, back in the day, it was basically like, all right, like let's kind of incentivize people to get people to go to the dentist, like the original dental insurance. They actually didn't even call it insurance; they called it a prepaid benefit. And the goal was like, hey, we're going to prepay for your cleanings, your tooth cleanings, and your tooth exams every year. It's already paid for. So if it's already paid for, like you should go, like use it, And in that way, it just got them employees into the dentist. And then if they needed more care, they pay, out of pocket, basically. That's how it started. In fact, I even found this old, like 1970s report, the Department of the Health and Human Services. It wasn't even called that back then. It was called something else. And they actually, in their own language, they did like a survey of all of the dental insurance products at the time, and the average annual max was $1,500. This was 1973.
And
right?
it still is 1,500, or some have 2,500. Isn't it that?
Yeah, it's insane. So, and it's funny because in that paper, I'll send it to you. In their own words, they actually used the terms like I don't know exactly. It was like basically they said dental insurance isn't actually insurance in their words, not ours. Because you always hear people saying that. So I was like, they said it too. So that's kind of with a problem here, right? So it started out like that, but now when you have this third party, now we start to have different incentives, right? Where it's like, okay, if I'm a patient and I need to get a filling, well, I'll get it done with you, and I'll pay you money because I want you to do a good job and I value that treatment. And for you as a doctor, you're like, well, I mean, I want to do good care and I want to get paid for it, right? So let me accept this. Now, once you introduce a third party in the mix, that's kind of determining yes, no, approved, not approved, et cetera, et cetera, et cetera. Now the incentives change because the incentives for a dental insurance company is to hold on to as much money as possible because that's how they make money. I mean, if that's their incentive, then the incentive is no longer getting as many people care as possible. It's no longer getting the dentist, paid properly. The traditional incentives kind of go out the door, where if you want to do a medically necessary patient on your orthodontic patient because they're class 3 and they can't eat properly, they can't speak, they got a speech impediment and they're getting made fun of in school, that's medically necessary. And you're fighting to get this done. And the nurse assistant on the other line is telling you, no, you can't do that. And this is where it really irks me, to be honest, because it's like, with all due respect, like, how are you going to tell me, about this maxillofacial surgery procedure and if it's medically necessary or not? So that incentive plan, the incentives kind of switch. What you're describing is aligning the incentives, right? You're like, well, how do we make it so dentists do want to take, like a public aid benefit, right? Which the point I think that you said very nicely was that I'm going to say in different words, you got to follow the money, right? And that's kind of actually for us, at least at Toothsome, that's kind of why we're starting with employers. Like if I had it my way, we would, start in the public sector because they're the ones that need it. But I think that in order to truly be able to kind of wedge yourself in to the market and actually go to market as a national company is we have to go to where the money is. And as much as I want as many people to get care as possible, employers are really trying to save money because of how expensive their health insurance is getting because of the economy. I mean, there's 50,000 ways. They want to save money, and they will listen if we say, hey, we can save you 50% of your dental insurance pay on your 50,000 person, employer, jobs. That's like, we're talking millions of dollars of savings. So that's kind of my approach. One other thing you should, just for you to check out, it would be kind of cool, is a company called Strive, Strive. They're working on what's called a portable benefit. So going back to what you were saying about the underserved, these are the people that don't have jobs at Samsung and at Tesla. They don't have insurance for their job. So whenever they get hurt or they need something, it's very difficult for them because it's 100% out of pocket for them. So what Strive has done is they've basically created a portable benefit, sort of for kind of like the gig economy, like people who don't work like a traditional W-2 job, where they're able to kind of pay into like an insurance product, but it goes with them, so like if you are an Uber driver or something, you're not technically employed, you move to California, whatever, you still have that benefit, and they have like a provider network where you can actually like get the treatment properly. So the time we're in right now is this innovative time where newer models are kind of coming out, and I really like your idea, by the way. I think that's awesome. For us, it's like a little more on the employer side, just because that's like where the majority of Americans get their dental insurance through, is through their employer. And that's kind of this concept, we can get into it, the direct contracting and kind of that whole method of basically getting rid of the middleman, and how do we align the incentives for all three, employers, providers, and patients.
Yeah, and well said. I really think that exactly the direct to consumer, where you kind of put it in an escrow account, that is most likely step one. And these big companies, conglomerates, are going to go for that because it saves them money. But then two, it's definitely going to start with that. That'll be 5-10 years, or it depends on how active your team is. In addition to how many companies you could sign on in that time, and then step two would be kind of be, well, where is that escrow going? Where's that? How does that kind of disseminate within and then it could be like, well, the escrow account, now we're just going to move it into this new insurance company, or you could keep that, but the insurance company might allow a little bit more benefits, a little more coverage potentially. Yeah, or however it works. But that's
Yeah,
wow.
it's
This
so
is
many new models that are out there. What's really popular now in medicine is this concept, direct primary care, where basically it's like the employer pays a subscription fixed per employee, and they get essentially unlimited primary care. So like doctor's visits, most of the time virtual visits, labs, any of that kind of stuff. If you need certain like a la carte things, like you need an MRI or something for your knee, or you need a specialist to go, that's like separate and that goes outside. But for just that, the majority of all the health claims, like the primary care, just going into the office, the most inundated portion of our healthcare system, primary care, what they've done is there's like, all right, let's build it in a way where it can allow employees to access a PCP within like a day, instead of like 40 days or however long it takes. So there are some interesting models in that route with direct primary care. Now there's even on the dental side, right? Like there's subscription platforms now, where basically, you have a patient who maybe doesn't have insurance, or they're like, hey, why don't you just pay us like $50 a month or whatever it is, and for a year, and that'll include, 2 cleanings, and like a bunch of discounts on whatever care you need. And I think it's a great model. That's definitely, there's a lot of kind of motion and movement towards these subscription-based models. The only thing is that like the employer, the company, they're still paying no matter what. It's the same problem with dental utilization. Like if the utilization is really low, you still get that what's called breakage in insurance, like money that's paid that really didn't go to anything other than the insurance company. So that's my critique with that model. And what's happening now on the kind of surgical side, like on the interventional side, direct specialty care, you could call it, where there are these platforms that have come out called centers of excellence, like models. There's a company called Carum Health. They do a really good job. Lantern is another one, where this is an interesting model. Like let's just say we're at Tesla, and a patient they need their knee replaced. So normally, you go to your PCP, you got to get a referral, orthopod, they got to get a imaging, labs, the whole thing, and then they schedule your surgery in the hospital, and the anesthesiologist happens to be out of network that day, whatever. So the bill is going to be in the facility fee, and it's going to be like 80 grand or something really high.
Yeah.
Where these platforms, what they've done is they've done all the vetting. They've found these awesome surgeons that work independently. They own their surgery centers, for example, and they kind of control the anesthesia costs, et cetera, et cetera. And there's a lot more data, by the way, in medical than dental with this, like outcomes. Like they want folks who have very low, complication rates and stuff like this, low readmissions and whatnot. And they'll say, hey, if you need your knee replaced, don't go to the traditional route. Go, find a doctor on this platform that we've already negotiated a price with. They've already been vetted, they're high quality docs, and it's at the outpatient surgery center. So it's kind of like going to see like an oral surgeon. It's like, well, it's my office. We're going to charge you this fee with my anesthesiologist. There's no facility fee. There's no insurance, middleman, all the 90% administrative BS. We're going to charge you 20 grand, right? And these are like bigger employers like Tesla and whatnot, where they're called self-insured employers. It basically just means that the way they do health insurance is a little bit different. Like they pay all their claims themselves. So if you're telling Tesla like, hey, instead of 80 grand, you can pay 20 grand for better quality, it's a no-brainer. And these are the kind of these centers of excellence models. So that's part of the provider side of what we're building. Is we're building this dentistry's first center of excellence. For example, if you're a general dentist, like if you have your fellow of your AGD, that they have like an honorary degree you can get for a certain amount of CE you've done. They have a master's program. The American Board of Oral Implantology, they have a diplomat program. They've done tons and tons and tons of CE. In my opinion, we should be rewarding those doctors, right? They're the ones that have put in the work. They're committed to quality. They're committed to lifelong education. Bring all those doctors together onto one network and let the employers refer their employees to those doctors. No middleman, cash benefit, and they know they're getting good care. And then the dentists are getting paid better because we can set the fee schedule better than like a regular PPO. Yeah. And the best part of it, which I know now from running a practice, the best part of it is that the admin is zero to get paid. This concept of RCM, right? Revenue cycle management. When I first learned about that, I was like, what? Like there's an entire industry to get paid? I mean, in no other industry do you do something and then, you need to hire like 40 people and deal like 6 months of admin work just to get paid. The admin work, there's actually a lot of studies done on this, administrative waste, where it's estimated that about 20 to 30% of all the dollars that come in via health insurance companies to providers, 20-30% out the door immediately, just on the admin of actually collecting the money. Oh, yeah. So if you can reduce that to zero, I mean, that's an automatic 20-30% bump without even changing. Even if you got paid the same fee for PPO, and of course, pay a little more on the PPO, well, now it becomes a no-brainer.
Right. Man, you got to keep me in the loop on this because I want to see how I can help you with that. If I can, I would really like to.
Yeah, man. I mean, I am a big fan of folks that are trying to change change systems, man. Because like what you're trying to do, I mean, just that idea that you described to me right there, and then what you've done with pre-dents. I mean, this is kind of like some advice that I got when I was just starting residency. It was like people told like older residents, like residency is what you make it, right? Like you can kind of just get by and survive, right, and be in survival mode the whole time, or you can get after it, right, like you did, right? I mean, you've built this audience, you've built this amazing platform. I mean, that's the difference. So when I meet people like you, it just excites me. It gives me even more energy. 100%, man. Yeah, no, I'd love to kind of be involved with you, keep you updated, and also I want to be involved in your projects as well.
Oh yeah, let's do it, man. I think I need that insight that you have from Toothsome and everything you're doing there, and then you said the what was it called on the medical side? This is what Toothsome is on the medical side. That we don't have it.
Yep, centers of excellence platforms.
Centers of excellence.
Yes. Yeah. No, it's cool.
Man, and the algorithm, because we can make such a very visually appealing model online that would allow people to just the Google search will bring it up. That's why I really want to create a map that shows you that, and then you could use filters like, well, I don't need a periodontist. I need an orthodontist because my kid's 17 and or 13 and needs braces. You could filter out everyone but the orthodontist, and then you could filter out based on distance from your house. And it's exactly what you're saying. And then maybe you need to get a little bit more, and you could call up someone. And it sounds like that's everything you're doing with the phone call. But if they could have this information, which is essentially like, right, the service is the information, that would help do it. And then you could already pre-qualify. Oh, did they take my insurance at that dentist office?
Yep. It just saves so much time. And actually, that's part of the vetting that we do is financial too, right? Because sometimes it's like, listen, like I just want, the cheapest thing possible, and we can find someone for that, or they're like, listen, I only want board certified, oral and maxillofacial surgeon doing my case. So it's like, well, we've got a few here, and this is who you go with. So that's that level of information asymmetry where I think is even worse in dentistry than in medicine, because we don't really have like the same protections or regulations in the hospital. And you're probably going to go through this pretty soon, but I'll tell you my story. When I first got my privileges, just like a local level 2 trauma center here, Ascension Northwest, I mean, even Chicago, that was at like Northwestern, it was like a much bigger hospital, but the credentialing process that you go through as a surgeon, it is like an in-depth audit of your surgical log, all of your credentials. I mean, it is like they will not let you in the operating room, right? Unless you've got, I mean, obviously you've got everything, but this is the level, this is the standard that they keep, right, for their surgeons. And to me, and I'm just like doing like, I'm taking like special needs kids, or like I'm doing very basic surgery for extractions and stuff. I'm not really doing these like, fibula recons. That's it. I'm taking teeth out, and I have the same level of an audit and credentialing process than, some of the more like involved procedures for the surgeons.
Yeah.
Now, you look at dentistry, we have people doing zygomatic implants. We have people doing even the new transnasal implants. I mean, you can do a zygomatic implant the day you graduate dental school because it's dentistry and it falls under the state. Right. So how is a patient supposed to know that I'm doing the right thing here, right? Like you're telling me this dentist is going to put me to sleep, do a full arch, do zygomatic implants right next to my eyeball, keep me alive, and somehow get a good outcome. Like the patient shouldn't be responsible for having to figure that out. We want to be that third party. So that's where, it's just the industry, it does come down to
I think that's step three, to be completely honest. I think step three is, I hate to say, I think it's going to be a law firm. I think it's going to be a law firm, but you have to have that insurance company that pays for preventative care. If you're only getting $18 for 2-surface filling, that's why everyone's going towards the implants. I mean, it's the financial incentive, right? Follow the money. If we could create that insurance structure that gets away of all these admins losing 20 to 30% and then over 55 to the admin in some places, that money goes back into the providers doing the surgery, doing the treatment, whatever it is. Once we can get that, and you're getting $200 for 2-surface filling, you don't need to be doing the implants anymore. You don't need to be doing the zygomatics.
Yep.
Once that insurance structure is in place and we get a bunch of providers on board, step three, right? Step one is corporations, like you said, the in-house, the customer, direct customer. 2 is the bigger insurance company to broaden it a bit so that all people can get this and providers get adequate reimbursement. Step 3 is enforcing the law firm that starts to clean up the disgusting stuff that's going on.
Like all the fraud.
You need to say you don't need to do zygomatic implants your first week out of dental school. You could stick with those fillings. You didn't even do a residency.
Yeah, and work your way up. Right.
And work your way up. Maybe you go to a residency so you know you know how to handle the complications of the zygomatic implants in the eyeball.
Yep.
It's going to come down to litigation, but you need to say, why were you doing that when you could just do the fillings like you're trained? You did how many fillings? How many zygomatics you did?
Yeah, I think the point you're making a good point when it comes to financial incentive, and that's an important, I think, topic to just hit on when it comes to, again, like now the provider's perspective. We talked about insurance perspective, patient perspective, but even the provider's perspective, financial incentive. Everyone's human, and this is where if you're driven by financial incentive, that's going to affect your clinical decision capabilities, right? And I kind of did a deep dive on back in the day. I was looking for other examples of where do we have like price suppression. I mean, at least my personal view is that I view the insurance companies like PPOs and whatnot as they're suppressing your price, right? They're telling you what you can charge, right? I mean, that's price suppression in my opinion. Yes, you agree and you sign a contract. Sure, it's not like it's a government, but it's a form of price suppression I think we can just agree on that. If we look at other cases of price suppression in the past, this is interesting. Back in the day, like I think it was like the 70s, airlines, like commercial airlines, they were actually all regulated by the government. They had regulated pricing because otherwise it was like crazy expensive to basically fly and whatnot. So they actually regulated the prices. They wouldn't allow them to charge certain things and whatnot. And then very few people had a good experience. Like people weren't really flying that much. It was a rare thing. Then what happened? Because basically there was no competition. There was no competition. There's only like a few airlines and they all kind of had the same prices. Government stepped in and they're like, wait a minute, we need to deregulate. And this was a big movement. They deregulated the entire industry, allowed little startups to pop up, and a lot more different airline companies came into play. And now you get a lot more variety in price and quality, and it just turned into a true market, like free market economics. And now what happened is way more people started to fly, and the industry started becoming healthy, and way more people start to get to fly around and use this. And the whole market transformed because of deregulation. And I kind of view this, if you take the parallel to dentistry, if you've got insurance companies that are working with large, like let's just say DSOs, like large groups, we're talking
Sure.
massive
Yeah.
DSOs, well, they're suppressing the fee reimbursements, right? Because that's how
Competition.
they're incentivized.
Competition. They're agreeing to raise the with the DSO, but they're not agreeing with the competition because it's a mom and pop shop. It's a yeah.
Yeah, right. So now, like, if you're a DSO leader, let's just say you're like the chief revenue officer or something, and you oversee like 200 offices, and you're looking at your PPO fees, and you can try to negotiate with them. And as a DSO, you've got a lot of negotiating power, but it's still a PPO fee. It's not going to be your regular UCR. And you're like, well, our private equity investors, we need to deliver some results because they need to sell to the next, so it's incentives, right? So what they're going to do, and I can't, I'm just saying, I'm speculating here, is that basically you'll notice some patterns. And once you get in the community, you'll see this too, clinically, is that some offices you're going to see are like way over treating, over diagnosing. And it's just like, why? Like, there's no like, I know you weren't trained like that, right? And you start to think, well, maybe their office manager is telling them like, hey, you got to produce this much, or, we have this quotas and whatnot. So now the decisions of treatment are no longer made just purely on diagnosis and patient preferences and what the doctor recommends. It's made off of financial determinants. So you'll start to see, I'll see these second opinions all the time, these treatment plans with like just a crazy amount of stuff. I'm like, a lot of this probably you don't need. And
Yeah.
it's a financial incentive. So now when you compare, let's go to like a fee for service environment where you have a free market dentist. They do whatever they want. They charge their own fee, which is going to be higher, but they're getting paid their fee. They don't have the pressure to meet those financial incentives. They can treat you like a regular patient. They're not worried about over diagnosing or like, I'm just going to treat you how you are because my fees are normal. I'm getting paid for what I'm doing. Why would I have to jam my schedule and meet
Right.
quotas? So that's the financial incentive where I think it's really important to correct, in our industry.
Yeah. 100%. And then another financial incentive that's already starting doctors and dentists in the negative is the educational debt. So, if they're going to come out in such debt, there needs to be some type of incentives, tax write off, some kind of healthcare, but there's got to be some kind of ways that you could pay that off in a reasonable amount of time. You can't be paying off your loans until you're 65 years old,
I
which
know.
is what we're going to start looking at, if not already.
Mm-hmm.
But yeah, man. Oh, these are all really big topics, and I'm really passionate about these topics. I really appreciate that we got into these.
Yeah, man. No, for sure. Yeah, there's a cool story that was told to me by a friend of mine, and this is back in the 90s, or something similar happened with cardiologists, I believe, or maybe it was cardiothoracic surgeons. But basically, the Medicaid reimbursement for, I think it was like a cabbage or something, or maybe it was like a PCI. I think it was smaller. I think it was like a PCI or something. The reimbursement, like, it got cut by like a third. It went down to like one third. And I'll just keep this all anonymous. But basically, he was behind a foursome in a golf course. It was like 3 or 4 cardiologists and like an anesthesiologist, and they were complaining about like, oh my gosh, guys, like, look at this reimbursement. Like, we're not going to, we're going to go to business. This is ridiculous. And they were talking about the times. They're like, well, normally I'll do one in like, 45 minutes or whatever, or like an hour. It's like, you know what? Like, I'm going to have to do like 3. I'm going to have to do one in 20 minutes now, and it's just like, you start to, and I heard that story and I did some digging, and there was a study that was done that showed the increase in the amount of PCIs that happened after that Medicare payment change. So
Yep.
as much as we all think that, doctors are noble and you swear an oath, you know, there there is a financial incentive, and until you remove that financial incentive, is going to be affected in some way, shape, or form. And price suppression and regulating your price and whatnot is just not. It does not. It's not part of the free market. So we really want to rebuild. How do we rebuild a free market in dentistry, right? Where allow dentists to participate in free market economics, allow there to be competition, because as a startup, like, I'm a startup. I have to take insurance. Like, it'd be foolish to try to be like a fee for service. So it makes it very difficult. But I have to,
Mm-hmm.
because that's the market norm. And if we want to make these big changes and we want to improve care, improve the financials of the employers, we have to do it in this way from the ground up. And
Yeah.
that's why I like having chats with you, Brandon, because it takes creative thinking. It takes a unique perspective, which is why I love chatting with oral surgeons about this, because you have like a hospital, like you have like a medical lens on. And then lastly, it takes guts. It takes guts to go against the norm. You won't imagine the amount of like comments and stuff. Like whenever I try to talk about like critiquing on insurance and whatnot, everyone's like, oh, like, just drop the insurance companies, or like,
It's not that simple.
just go be an administrator if you want to make more money. I'm like, guys, like, this is our problem, right? Like, us as an industry, we need to kind of think like innovators, right? Instead of just kind of like complaining about the status quo. Let's make a difference, right? Like,
The only way we get
how do we
better.
take action?
Yeah, yeah. And another fundamental, just to lead on that, in the hospitals, they were that forced on the cardiologist. They were counting how many times they would have to make the same amount. How many would they have to do in an hour now to make some amount? Something that you hear with the surgeons in the hospital when you're talking with the attendings on other services, especially on the medical side. They always brag about how many surgeries they did that day, how many they
Yeah,
got in a certain amount of time. Oh, I just did that orthognathic in 2.5 hours,
I know.
right?
I
It's
know.
always a number. It's always a stupid thing. Yeah, but you know how many complications go up when you're trying to squeeze a surgery in that amount of
Yes,
time? But this is, you're talking about the foundation of it. Well, why are we basing students' prestige and aptitude based on
on
test scores the
time.
entire time? I mean, this is, and then it becomes time, because in residency you're not making any money. It becomes speed and time. Oh, who's the fastest, who's the
Right.
best? Speed is definitely excellent, right? You want to keep the anesthesia down to as minimal as possible. If you could get more surgeries in a day, that might add to your pocket, that might improve your quality of life. But the fact of the matter is, we shouldn't be fighting for more surgeries in a less amount of time. We should be getting reimbursed adequately. A patient should have the appropriation to afford all that time that the surgery takes. It's just
Yes,
that.
exactly. Yeah.
Yeah, I really think it starts on the insurance level. It starts with everything you're doing. I'm really excited to hear about it and see where Toothsome can go. I really want to be a part of your project. I really
Yeah,
want to
man.
know about this. I just want to learn. I want to see where I could be. I love that. Exactly what you said. It takes some creativity. It takes some innovative thinking. I went to engineering schools, and they make you read about like books like Steve Jobs, and it was all the innovators that made those massive advancements.
Absolutely.
That's what we need. That's what we need. We get bottled where it's like, there's so many ways to do a certain surgery, right? But we're taught maybe to do it this one way with this attending and this one way with another attending. But you have to find and mesh and innovate your own little way to make it forward based on your strengths, right?
Yeah, yeah. Like, you have to kind of, think of it in your own way and not be afraid to pursue that. There's a quote that I like that Henry Ford said back in the day, and obviously he essentially invented the automobile. And it's funny because in an interview he said, he's like, if I actually listened to what people wanted to do, I would have built a faster horse, right? Because
Yeah.
people don't like understand, like, you have to think differently, right? If we just listen to what everyone wants, it's like, oh yeah, make breed a faster horse. No, we want to build an automobile. It's like when the iPhone was built, right? Like, the same
Yeah.
thing happened with BlackBerry. Like, BlackBerry was like, yeah, like, we're the future. You need to have the keyboard. Like, we're gonna have our own privacy. No, Apple came in, they built the App Store. I mean, they totally
Mhm.
changed the game. It's thinking, how do we think outside the box and not within the same confines of the way this legacy industry has been, for the past, 100 years. So yeah, so it's a fun time to be alive right now, and especially with you graduating, where you can kind of start to explore these concepts and ideas, and you'll have more time to do
You got to
to
get
do
after
these
it, man. Yeah.
pursuits.
The time, maybe a little more capital. Capital's. Oh, one last question for you. I wanted to ask
Hmm.
you before. So you're at 3.5 days a week now. Which days do you work? Which days are
So
you
I
on call?
do uh, I do Monday full day. I say full day. I finish at like, at least we stop seeing patients around like 4:30. Then I do Tuesday half day, so we'll stop around like noon.
Oh, you start.
The first post stops, we do like a post stops at like 7:45, and then the first surgery is at 8 a.m. And we'll do surgeries like all the way to like 1 o'clock for like a full day. And I'm sure you guys do that. Like, we do like surgery in the morning and then like consults in the afternoon. I
Generally,
still
yeah.
do it that way. I kind of like it that way because then I'm done with sedations and stuff for the day.
Yeah.
And then Wednesday we'll do a full day. Thursday is like no day for patients. That's kind of like I'm in like meetings and calls and or with the engineers. I'm in design. All it's just like a bunch of stuff I'm
Got
working on. And then Fridays we basically do a full day. So it's kind of like a good balance.
it.
For me, I think that's a perfect balance. And then worst case scenario, if I need to go to the OR or something, I still have that buffer. I can book a Thursday or something
Yeah.
where it's not impinging on the patients here.
Yeah, yeah. Oh, that's excellent. That's a great setup. Nice schedule. You got yourself a good routine. Hey man, I'm excited. We got to keep we're in touch over time here.
Absolutely, man, for sure. No, I'd love to continue sharing what I'm doing, and I'd love to help out too, kind of develop out concepts that you're doing. And it's not every day that you chat with someone with similar concepts. So just love what you're doing, by the way, with what you've built, and just congrats, man. Like really, I've been there, and
It's
I
similar
just think
ambitions.
that
We wanna make a brighter future than the current day and age. Yeah, man,
absolutely,
I
man,
appreciate that. So I'll get this posted within the next couple days. I have like an order of some I got to get up, but this was a great chat, man.
for sure,
I
man,
really wanna we got to touch base again 6 months or so for another. We'll touch base in between, but for another podcast in six
for
months, I
sure.
want to know
Yeah,
where
yeah.
you've
Other
been.
topics too we can talk about for sure, man.
Yeah, definitely, definitely. All right, man. I'll let you go. I know you're busy. Thanks for coming on and making
Awesome,
some
man.
time for me.
It's good to meet you like virtually, and thanks for having me on. Appreciate it, man.
You too. Yeah. All right, man. I'll talk to you soon.
All right, take care. Bye.